Good morning, everyone. So I'm Dr. Michelle Ryan. I'm one of the staff neonatologists at the Montreal Children's Hospital, and this lecture is going to go over neonatal resuscitation. So a lot of our objectives that we're going to cover in this lecture are how to prepare for a delivery if it was to happen in the emergency department, go over a bit of what an APGAR score is and the importance of it, as well as go over the algorithm of the neonatal resuscitation program, or NRP. We'll also go over intubation. So NRP was originally launched in 1987 and is really the standard of care that we use in newborn resuscitation after a delivery. Now the goal across Canada, the US, and internationally is to have at least one professionally trained person at every delivery in the country who knows NRP. Every few years, the ILCOR group, the International Liaison Committee on Resuscitation, looks at the best available evidence and assesses whether changes to the NRP algorithm need to be made. So the key behavioral skills within NRP are know your environment, anticipate and plan, assume the leadership role, effective communication, delegate, allocate your attention wisely, use all available information and resources, call for help when needed, and maintain professional behavior. So an APGAR score. So think of this as a Glasgow Coma Scale score. It gives you, or it gives another person, an immediate snapshot on how depressed that baby was at birth. The maximum score that you can get is 10. As there are 5 categories, and the max score within each category is 2. The lowest score you can get is 0. So for a baby, if their APGAR score at 1 minute, 5 minutes, and 10 minutes, that's when we do the scoring, is 0 to 3, this signals that the baby was extremely depressed. A score of 7 or more usually means that the baby may be having some difficulty, but otherwise is likely more stable. We do the scoring at 1 minute, 5 minutes, and 10 minutes of life, so immediately after delivery, after expulsion of the body from the mother, is when we start timing. And we continue the scoring every 5 minutes until we have at least a score of 7 or greater. And we do this up to 20 minutes of life. So before a baby is born, these are the 4 primary questions you need to ask. What is the expected gestation? How many babies am I expecting? Is the fluid clear, or is it meconium stained or blood stained? Are there any additional risk factors, such as maternal fever? Are you concerned about choriamnitis? Is there gestational diabetes, and we're expecting a large for gestational age infant? Things along that line. So before we get into algorithm, one of the key things I want to stress is airway, airway, airway. The focus for NRP is on achieving effective ventilation. Most low heart rates in newborns are secondary to apneas or ineffective ventilation, not a cardiac problem. So the most successful indicator of effective ventilation is a rising heart rate. So this is the algorithm from start to finish, and we'll go over this in detail. So the initial steps. Does this baby need resuscitation? As you may recall, your 4 questions. What is the gestation of the baby? How many babies? What's the fluid like? And are there any additional risk factors? The baby's then born, and then we need to clarify. Is it actually a term baby that we were expecting, or maybe the baby's actually more preterm than what we were expecting? Does the baby have good tone, and is the baby breathing or crying? If the answer is no to any of these questions, we need to bring the baby over to the PANDA and or the resuscitation warming table and evaluate the baby. We clear the airway, we position the airway, we dry, we stimulate, because sometimes if the baby's in primary apnea, they just need stimulation to have that trigger to breathe. However, if there is still apnea or gasping, such as ineffective respirations, or a heart rate below 100, we need to initiate PPV. If the baby has a good heart rate above 100 and is breathing, but the breathing looks labored and there's retractions, we initiate CPAP. At any of these points, we need to start an SpO2 monitor, which we place on the baby's right wrist. So we now said this baby has a heart rate below 100 and the baby has apnea. So we're going to start PPV. And we're going to do PPV for a minimum of 15 seconds, and then we're going to check for chest movement. So after initiating PPV, the pattern is breathe 2, 3, breathe 2, 3, breathe 2, 3. On the breathe is when you're actually giving your breath. This provides about 40 to 60 breaths a minute. Your first assessment of your heart rate, as I said earlier, is after 15 seconds of doing this PPV. You have 3 options. 1, your heart rate is increasing. So you would announce heart rate is increasing, and you would continue PPV and assess the heart rate after another 15 seconds of PPV. If the heart rate is not increasing, you need to check to see whether your chest is moving. If your heart rate is not increasing, but your chest is moving, continue PPV for another 15 seconds and reassess the heart rate. At this point, you are announcing heart rate is not increasing, but chest is moving. Continue with what you're doing. However, if your heart rate is not increasing and you look and the chest is not moving as you're providing PPV, you then need to do corrective measures, and this is where your Mr. SOPA comes in. At this point, the person would announce heart rate is not increasing, chest is not moving. This alerts the whole team to what the next steps are going to be. So for the corrective steps in ventilation, this is where Mr. SOPA comes in. I've broken them up into the Mr., MR. These are your first 2 steps. Most of the time, you can achieve adequate ventilation with just these first 2 steps. That's readjust the mask, so making sure that it covers the mouth and the nose, but not the eyes. And you may need to have a two-hand technique and a 2-person technique for bagging the baby. Also reposition the airway to make sure it's in the sniffing position. After doing this, you will give the baby 5 to 6 breaths and see whether the chest is now moving. If the chest is not moving, despite doing the mask readjustment and repositioning the airway into the sniffing position, suction the mouth and then each nair and open the airway. Open the baby's mouth, reapply the mask, and give another 5 to 6 breaths. If the chest is still not moving, after you have done these maneuvers, you'll then increase your pressure. So the initial starting pressure that we use is 20 over 5, a PIP of 20 over a PEEP of 5. And so if you need to increase your pressure, maybe the lungs are stiff and you need to give more pressure, we increase it typically by 5 centimeters of water each time on your PIP. The max you should be going is 40, but most often in practice we go to a maximum of 30. So we would first then go to 25 centimeters of water for your PIP over 5. Give a few breaths. If that still is not achieving adequate ventilation as judged by chest movement, then you need to increase to 30. And then if that's really not working, we then typically in practice go to the alternate airway, but the NRP says you can go to a maximum of 40 centimeters of water. If, on the other hand, that is not working, you then need to consider the alternate airway. This is either intubation or inserting an LMA, but your baby really should be over 2 kilos to have an LMA inserted. So the indications for intubation. You're unable to effectively ventilate with a mask, and you have worked through all the prior steps of Mr. SOPA, the mask readjustment and reposition of the airway, the suctioning of the mouth and then the nose and opening of the mouth. The pressure increases, and now we are still not moving the chest effectively. We're still not able to achieve adequate ventilation, and we're in the alternate airway route. We also need to make sure we're intubated before starting chest compressions, and we would give 30 seconds of PPV through the endotracheal tube before initiating any chest compressions. We may also need to intubate if we need to administer medications. We can administer epinephrine through the endotracheal tube, or if the baby is preterm, we might need to administer surfactant. There are special circumstances where a baby is born and having respiratory distress, and we would need to intubate. These would be a congenital diaphragmatic hernia, where we want to intubate instead of providing PPV, just through a mask, a gastroschisis or an omphalocele, or bilateral choanal atresia. Please keep this guide handy because this tells you how far your endotracheal tube should be inserted because it does differ based on your gestation. Once the baby is around 2 kilos, we typically use the 6 centimeters plus the weight in kilos to determine the depth of insertion as measured from the lip. But with babies that are more preterm, so usually 34 weeks gestation and less, the depth can actually differ. So there's this guide. The size of the endotracheal tube also differs. So babies that are less than 1,000 grams, we use a 2.5 sized endotracheal tube. For babies between 1 to 2 kilos, we use a 3.0 sized endotracheal tube, and for 2 kilos and above, we use a 3.5. Another way to measure the depth that you should be inserting your endotracheal tube is to measure between the nasal septum and the tragus. So you take a measuring tape and you start at the nasal septum and you measure to the ear tragus. This depth plus 1 centimeter is how far you can insert your endotracheal tube. We know that as the gestation age decreases, so the baby is more premature, the glottis becomes progressively anterior. So I've given you 2 pictures here. One is the laryngoscope is not inserted far enough, and so you're just getting tongue and pharynx when you're looking. And the other one is that the laryngoscope is inserted too far and all you're seeing is esophagus. So for the first one, if it's not inserted far enough, you need to push your laryngoscope deeper. Whereas for the other one, if all you're seeing is esophagus, you know that's too far. Your glottis is going to be above that, and you need to slowly withdraw your laryngoscope until your glottis comes into view. These are your landmarks that you're looking at. So here you can see the epiglottis, the glottis that we're aiming for, and then the esophagus is below. So say we are now have intubated, we have confirmed placement of our endotracheal tube because we have color change on our colorimeter, our CO2 detector, we have misting in our tube, we have equal air entry bilaterally. We're now going to give effective ventilation for 30 seconds. It's 30 seconds of moving the chest. We then assess the heart rate after that. If the heart rate is below 60, despite 30 seconds of effective PPV that essentially moves the chest, that is the indication to start chest compressions. So performing chest compressions, we only now use the encircling hands technique. We put our thumbs on the lower 1/3 of the sternum, as this generates higher systolic and coronary perfusion pressures. And the ratio is 3 compressions to 1 breath. So even though the baby is intubated, we don't perform these maneuvers independent of each other. So the compressor counts out 1 and 2 and 3 and breathe. And the breathe is when the person who's managing the airway gives a breath. On the 1 and 2 and 3 is when you're actually compressing the chest. The depth is 1/3 of the chest AP diameter. Other key point is to make sure that your thumbs are pointed down. You don't want to be squeezing the whole chest wall, as that is ineffective. You need to make sure that your thumbs are actually pointed down and you're delivering downward pressure when you're doing your chest compressions. If you have done 60 seconds of chest compressions that are coordinated with your ventilation and your heart rate still remains below 60, that is when you actually need to administer epinephrine. Now, we have epinephrine that you can give once through the endotracheal tube, but while you're waiting for an intravenous access, we only use 1 in 10,000 concentration of epinephrine. And your endotracheal tube epinephrine, the dose is 1 ml per kilo, but only to a max of 3 mils. So if your baby weighs, for example, 4 kilos, we still would only provide 3 mLs of epinephrine through the endotracheal tube. If your baby, on the other hand, weighs 500 grams, you would only provide 0.5 mLs of 1 in 10,000 epinephrine once down the endotracheal tube. We do not follow this by any flush. This is only as a temporizing measure until we can gain IV access. The quickest and most reliable way is to insert an emergency umbilical venous catheter. I will give you a link in the email to have a YouTube video that'll show how to quickly insert an emergency umbilical venous catheter. When you have IV access, either through a UVC or likely an IO, if you aren't able to get UVC access, then the dose is again the 1 in 10,000 concentration, but it's 0.1 mLs per kilo, and there is no maximum. So if you have a 4 kilogram baby, you give 0.4 mLs of 1 in 10,000 epinephrine, followed by a 1 ml flush, whereas if your baby is 2 kilos, you give 0.2 mLs of 1 in 10,000 epinephrine, quickly followed by a 0.5 to 1 ml normal saline flush. You would then immediately continue your chest compressions. If after another 60 seconds, the heart rate is still not improving to be above 60, where you can stop chest compressions, think about whether the baby might need a volume expander. This might be normal saline or it might be O-negative blood, depending on the context in which your baby was born. If, for example, baby was born and there was a severe placental abruption or a severe maternal trauma where you think the baby may have lost blood, I would give O-negative blood. If you think the baby might be septic, then normal saline might be a good starting point. We give these, again, through IV, 10 mils per kilo for both, and we give it over 5 to 10 minutes. If your baby is intubated and deteriorates, then you think of the DOPE mnemonic. So, did my endotracheal tube displace? Is there obstruction of my endotracheal tube, either with maybe it's meconium plugs, maybe it's thick secretions, maybe it's blood, and that needs to be sectioned out. Is there a pneumothorax that might need emergency needle decompression for drainage? Or is there an equipment failure? Maybe the oxygen has come undone from the unit. So to recap, as you can see, we start when the baby is first born. We assess whether the baby is term, has good tone, and is breathing or crying. If the answer is no to any of these questions, they come to the warming table and we maintain their temperature, we position their airway, we clear the secretions with suctioning if needed, and dry and stimulate them off the wet blankets, etc. If the baby still has either any apneas or gasping or heart rate below 100, all of these are indications to initiate positive pressure ventilation. You would place the baby with a sat probe on the right wrist, consider an ECG monitor, and deliver effective breaths using the ratio of breathe 2, 3, breathe 2, 3, breathe 2, 3, where you're squeezing or you're delivering your breath on the breathe. This gives 40 to 60 breaths a minute. We reassess our heart rate after 15 seconds. If after 15 seconds our heart rate is not increasing, we need to check to see whether the heart or the chest is moving. If the chest is not moving, then we need to work through our Mr. SOPA, our corrective measures for ventilation. If our heart rate is not increasing, but the chest is moving, give another 15 seconds of PPV and reevaluate before moving on. If your heart rate is increasing, again, check after another 15 seconds. Your Mr. SOPA, again, is first, it's the MR, mask readjustment, repositioning the airway, 5 to 6 breaths, a check for chest movement. If no chest movement, move on to SO, suction and open the airway. Give another 5 to 6 breaths. If the chest is not moving, move on to pressure increase. By increasing your pressure 5 to 10 centimeters of water each time, giving 5 to 6 breaths in between to see whether that starts moving the chest. If that is not improving the chest movement, proceed to alternate airway, which is you intubate the baby, or you put in an LMA if the baby is over 2 kilos and you have an appropriate sized LMA. Once we have assured that we have effective ventilation as judged by good chest movement, we then give 30 seconds of effective PPV. We assess the heart rate after 30 seconds of effective PPV. If the heart rate is below 60, then this is an indication to start chest compressions. The baby needs to be intubated, and we then coordinate our compressions with a 3-to-1 ratio, compressions to ventilation, and we do this for 1 minute. If our heart rate remains below 60, despite 1 minute of chest compressions, that is your indication to proceed to epinephrine. Epinephrine can be given every 3 to 5 minutes. And then to go back, if your heart rate is above 60, but below 100, you continue your PPV and keep reassessing your heart rate. If your heart rate is above 100, but the baby is still not breathing effectively on its own, you need to continue PPV. So as a quick reminder, airway, airway, airway. Clear the airway, provide PPV, remember Mr. SOPA, because effective ventilation almost always improves your heart rate. Keep the baby warm. It's very quickly that a baby can become cold. So please, please, please keep the baby warm, keep the baby breathing. And this is an equipment checklist for neonatal resuscitation. Thank you, and I look forward to working with you.